Good afternoon, and thanks for coming here. And everybody, welcome to Aspen. This is one of the first events we have here, and this is always a fantastic event, so thank you guys for being here. And I want to talk here a minute about Dimitri Daskalakis. When you talk about people having resumes as long as your arms, in his case, you need both arms because he has an extensive resume. An MD, MPH, he serves as the director of the CDC's National Center for Immunizations and Respiratory Diseases. Think all those respiratory diseases that are out there. That means he also leads the organization within the CDC that heads its bird flu response, and that's what we're going to talk about today. Dimitri recently served as the deputy coordinator of the White House's Mpox response, where he successfully led vaccination and public education efforts that helped to halt the advance of that virus. He began his career back in the day as an attending physician at Bellevue Hospital in New York City. There he spearheaded several local public health programs and ended up on community and testing and prevention for HIV. He served in several healthcare and public health capacities in New York City, most recently as the Deputy Commissioner for Division of Disease Control at the New York City Department of Health and Mental Hygiene. During his tenure there, Dimitri served as the department's incident commander during the measles outbreak of 2018 and 2019, and I'm sure we all remember the 2020 COVID-19 public health emergency. For those that were in New York City, you know how bad it was in New York City. He was the one that helped us get through that, and numerous other emergency responses. Having worked at both the local and national level, this gives Dimitri a unique understanding of outbreak emergency response efforts and what is needed to make sure we all stay healthy. And today we're going to discuss bird flu. And right now, all 50 states and at least 23 countries have reported cases of avian flu, mainly talking H5N1. The US alone has detected the virus in almost 170,000 wild birds, commercial poultry, and hobby flocks. Think backyard flocks that people have. It has also been found in more than 1,000 dairy herds. The cost of culling animals has been vast, but so far the risk to humans has luckily been minimal. Will it stay that way? Are we prepared if it doesn't stay that way? How are the triumphs, the errors, and the lessons we learn from past viral outbreaks being used here, and how will they be used going forward? Dimitri?
Thank you. Thank you very much. So thank you so much, John. I guess that is an introduction that only a mom could love. So a little voyage through my CV. So thank you all for being here. I want to start by saying that. So I think I think you're still interested in bird flu, which is really good. I was like, is everyone going to show? And it seems like the answer is yes. But before I go to bird flu, I want to talk a little bit about what CDC does and what the National Center for Immunization and Respiratory Diseases does, so that you have a sense of what the work is. So the work that we do every day is what we leverage for an emergency response. So the way kids get their vaccines, the way we figure out what would be the right sort of influenza that should be in the flu vaccine every year. That work is the work that happens every day, and it keeps the system warm for when we need to actually flex to take care of something that's an emergency. So I'm an infectious disease doctor, and I like analogies, and I think that the best analogy is to compare CDC and NCIRD, the National Center for Immunization and Respiratory Diseases, to the immune system. And so let me walk you through that analogy, and then we're going to talk about H5, bird flu, and talk to you about how we do that work together as a federal entity, as well as our partners in state and local jurisdictions. So the immune system is made out of cells and antibodies that work together to protect the body from external threats, or sometimes internal threats. When I think of the immune system, it has three main functions that I think about. So the first is detection, the second is response, and the third is prevention. So how does CDC and NCIRD work to detect? Just like the immune system has cells that patrol the body, and when there's something in there that's not supposed to be in there, it grabs a piece and presents it to other immune cells to recruit them and to start a robust immune response. So moving from there's something wrong to action. So that's the first thing that we do at CDC and NCIRD from the perspective of respiratory diseases, and especially the flu. So we really work to detect biothreats, and we do that through surveillance surveillance systems, through work that we do in our laboratories, work that we support in other laboratories, as well as the work to, when you identify a pathogen, to characterize it so we can learn the most about it from its genetic sequence all the way to how it acts in humans and other animals from the perspective of immune response. We also work not only to detect new pathogens, but also to tell you the story of the things that we know. Every year, we monitor flu. We see what's circulating, and we then help decide what's going to be in the flu vaccine. That same exact system, there's a lot of excitement. That same exact system that we use to sort of detect what's going on with the flu virus and help us figure out what should be in a vaccine is what detects the needles in the haystack. So let me give you an example that's not bird flu. This is now state fair season. This is when every year this sensitive system detects swine flu. So we know that there are flus that live in pigs, that if there's close contact with humans, usually children can acquire that flu. Every year we detect it and we find it through that surveillance system. That's the same surveillance system that we use to tell you what's going on with avian influenza. So that's detection. The second part is response. And that's when the immune system wakes up and it uses its cells, it uses antibodies to really both address, destroy, or mitigate a threat that is coming into the body. And that's really what we do every day. And that is by providing up-to-date information, guidance, data, and tools so that public health practitioners, medical professionals, and lay people are able to make informed choices to protect those that they serve, their families, and themselves. So let me sort of push that analogy further. So in the immune system, there are effector cells. Those are T cells and B cells that wake up to actually respond to an infectious threat. And then there are helper cells. Helper cells kind of orchestrate the whole system. CDC is like the helper cell. So what we do is take the data in, process it, and give information out that then stimulates our effectors, that's public health professionals, medical providers, and people, to do what's right to prevent those infections and mitigate the risk of those infections. So the signals that we give, the information that we provide, allows for orchestrated response. And then the last is prevention. And I like to think of CDC as really providing the immune memory that the country needs to be able to respond to many of these pathogens, and specifically flu in this example. So just like the immune system, once we've seen it once, we have a memory in our immunity that reminds us how to address it. And at CDC, we do something that you probably don't know, which is every year, we look at what's circulating for flu, and we create these things called candidate vaccine viruses, or CVVs. So those CVVs are things that we put in the bank, and if that virus pops up or something similar, we have that immune memory so that we can flex up and produce a vaccine in the event that there's something new and emergent. So spoiler alert, we have CVVs that are very similar to the bird flu that's circulating in cows and poultry. And 10 million of those doses have been produced in the event that we need to launch a vaccination effort. We don't need to right now, and I'm going to tell you why as we get deeper in the talk. So, CDC, detect, prevent, respond. And so that brings me to bird flu. And I guess this is why you actually came, not to hear about what CDC does, but I think framing it is really important. So bird flu, well, let me go back another second. Flu is not one virus. Flu is a whole swarm of viruses. They have different names based on what proteins are on their surface. So H5N1 is based on the hemagglutinin and neuraminidase, and that's its signature. And then even in H5N1, there are lots of different other genotypes that can be seen. So flu is a swarm, and there are flus that we see every day. Those are the seasonal flus, and then there's emergent flus like H5N1 that we haven't seen, nor have we seen its relatives, so it could potentially pose more of a threat. Now, right now, when you're looking at bird flu, it's what's called a panzootic. So that's the same as a pandemic. So I'm going to put my Greek school hat on. Zoo means animal, demo means people. So it's a panzootic if it's in animals, and it's a pandemic if it's in people. And so H5N1 is a panzootic in wild birds. Now, it doesn't just stay in wild birds. So, I mean, I think birds are, the older I get, the more interested I am in bird watching, and I think that that's what happens. And as you know, they're kind of predictable where the birds are going to be, what migration patterns look like, but they're really not controllable. And so these birds have H5N1. They tend to have gastrointestinal symptoms. These viruses tend to live in the GI tract and also in the respiratory tract. But what happens is these viruses don't just stay in birds, in wild birds. They can go into backyard flocks. Quite famously, based on what you've seen in the news, it can go into commercial poultry, and they can go into both aquatic and land mammals, whether they're domesticated or wild. And so that really is the story of the outbreak that I'm going to talk about, which is the introduction of H5N1 from likely wild birds to cows for the first time ever. I'll tell you, I'm an infectious disease doctor that sees humans. I know everything about dairy cattle now. It is shocking, the stuff that I've learned. And so that's one of the thrills of infectious diseases, because the animal world and the human world are really close together. And all of a sudden, you think that you're an expert in one thing, and then guess what? You have your friends in veterinary medicine, you approach things in a One Health way, and you become an expert in things that you don't expect. So H5N1 isn't new. We've known about this virus since 1997. We saw this in wild birds, and then we saw it in humans. In fact, since 1997, there have been over 1,000 human infections with H5N1 reported throughout the world. And as you heard, that's in 25 countries. The severity of that infection can be very, very mild to very, very severe. In fact, and we're going to get back to this as I talk, globally, 50% of cases of H5N1 have been fatal. So why haven't they been fatal here? We're going to talk a little bit about that. Since 2022, we had a little bit of an increase in cases again. There have been about 118 human cases that have been reported worldwide. 70 of them are ours in the United States. Before that, we had only had one H5N1 case before, and that was in someone who was involved in culling a poultry flock that was infected with H5N1. So this is a lot different. Now, human-to-human transmission has been detected in other parts of the globe. Very specifically, it's been in people who are caretakers, usually blood relatives, who are taking care of people in their home who have H5N1, and usually that has ended with just one transmission, so no sustained transmission. So there has been no human-to-human transmission reported in the United States, and there has been no human-to-human transmission, even unsustained, really, that we've seen in the world since 2007. So it seems as if this virus is really a spillover. It is an event where you're exposed to an animal, and then people get the virus. Does that mean that we let down our guard? No, because we're the immune system for the country. And I'm going to tell you the story of why we have a lot of vigilance and maintain vigilance in case this virus changes, because I will impress upon you that flu is tricky. Now, let's talk a little bit about the biology of avian influenza just for a moment. As I told you, about 100 species of wild birds worldwide have been observed to be that can be infected with H5N1. They're found in lots of birds around the world, including common birds that we see in our backyards, like sparrows, pigeons, and crows. It usually lives in the GI tract of the birds, can manifest itself as gastrointestinal illness, but also respiratory illness as well. When you think about bird flu, there's highly pathogenic and low pathogenic bird flu. When they refer to highly pathogenic, it's about to the birds. So there's low pathogenic bird flu, birds get sick, they get better, it goes away, and highly pathogenic, which is what you see when you talk about the bird flu going into poultry flocks where poultry start to die. So it becomes highly pathogenic. Now, the way that this spreads is direct contact, so bird-to-bird contact, bird-to-animal contact, and also environmentally. So if there is a contaminated environment and people are exposed, people or animals can get bird flu. And it can also be transmitted through the air or in dust. Now, in this outbreak and in a lot of other bird flu events globally, people who are at the highest risks are folks who have close encounters with the animals, whether it is because of their work or it's because of their recreation. That's who gets bird flu. So whether they're working with birds, if they're bird watchers, hunters, taking care of bird flocks, and in this situation, which is new, if they have close contact with cows who are infected or products from those cows. Included on the list are veterinarians as well as folks who are in animal or public health emergency responses. So this, we had a big surprise in March last year. Our friends from the USDA, through our long-standing relationship with them, called public health, called CDC, and said, an astute veterinarian in Texas couldn't explain why there was something wrong with the cows they were caring for and decided to sort of cast a wide net and tested for bird flu, H5N1, and the cows have bird flu. That's the first time that's ever been reported. So what did a sick cow look like? So these dairy cows, and specifically dairy cows, all of a sudden started to have a drop in their milk production. And the milk became kind of goopy. It's called colostrum-like, so thick, sort of cottage cheesy and gray, because something was infecting the udders of the cow. And so that noticing the decrease in production in milk, noticing that it was clumpy and not healthy looking, led to testing. And that testing identified herds in Texas that were infected. So before I tell you more, USDA did a lot of work. And what they've discovered in their evaluation of this is there was likely a single exposure, a single introduction from birds into dairy cows in Texas. Now, how then did it go from a dairy cow herd in Texas to 1,073 dairy cow herds throughout the country in 17 states? This is where I learned all about dairy cow mobility. Who knew? So they travel a lot, and there's a lot of movement of dairy cows between states, between farms, and a lot of investigation happened at USDA, and it seemed as if this wasn't something that was transmitting between cows through a respiratory route, but through some kind of contact, whether it's cow-to-cow contact or the metal equipment that's used to milk the cow. Yeah. So it's the contaminated material is what probably led to transmission, and ultimately what's been a really big outbreak in cows. Now, since that time, it's not just been cows. In fact, that 1,073 dairy herd number is impressive, but not as impressive as 174 million poultry that have also been affected by this. Now, realistically speaking, that's the way we're used to bird flu acting. We're used to poultry infections. We're used to the culling that needs to happen to control the virus. So the cow part, that's what's new and different. And as always, about 13,000 wild birds have been detected with bird flu, and that's not a surprising finding because it's an epizootic. So it's just an epidemic in those animals. So as always, working closely with USDA, we were like, okay, there's something going on in cows. 1 week later, it wasn't just in cows. There was a dairy worker in Texas who developed red eyes and respiratory symptoms, and that individual tested positive for H5N1, becoming the first case of H5N1 transmitted related to dairy cow exposure. Since then, we've had 70 cases in the US, and it's a mixed bag. 41 of those cases have been in people who have been exposed to dairy cows. 24 have been related to poultry culling, so killing the chicken flocks that are infected with H5N1, which we can talk about later, and then other animal exposures, including what's the more traditional animal exposures seen around the world, which is backyard or wild bird exposures. Additionally, remember I told you about that influenza surveillance system that finds needles in a haystack? We also found 3 people who had H5N1 infection with no animal exposure using that system. So that's that detect piece of the immune system. What's been interesting, and I'll try to give you some hypotheses about this, is that 94% of the US cases have been really mild. And mild means my eyes are pink, I have respiratory symptoms, but not all of them have been mild. We had 1 death that happened in Louisiana, and that was related to someone who had exposures to wild birds as well as a backyard flock. Still though, we're not seeing a trend toward increasing severity of bird flu. It, in general, is extremely mild in the US when people acquire the infection. There has been no human-to-human transmission, which I've said a couple of times. In a second, it'll be clear why I say it, and it's why we're watching the situation carefully and continue all of that other detection work so that we are primed for a response in the event that we shift from more preparation into activity. So why do we care so much about bird flu? Like, why is this such a big deal? So I go back to the source. Flu is a really tricky virus. It can change rapidly, whether it's through shift or drift. And those are the technical terms. But what shift means is, well, here's a secret. Flu viruses are kind of sexually active. Shh, don't tell anyone. So their genomes are split up into parts. So if 2 flu viruses infect the right kind of animal, you can have a new kind of flu virus, a Frankenflu virus, that comes out of that animal. And if it is the right or maybe wrong combination, it can be better at infecting people. And if it's just new enough, people may not have an immune system or memory that's able to handle that virus as well, and so their disease may be more severe. The other way that it can happen is drift. So that's little mutations here and there, and if the right combination happens, the same outcome can occur. So the flu viruses, the H5N1 viruses that are circulating right now in animals are avian. They're avian in nature, which means that they really do use receptors that are the receptors that birds have. If that changes and they become better at binding receptors that humans have, especially in their upper airway, we go to a more humanized flu, and that is how you create a pandemic influenza virus. So that's why it's such a big deal. And what we do at CDC, part of our work, is to really think about risk assessment. And we really think of risk assessment on 2 levels. What is my risk, our risk today in the population? And what is the risk of this virus emerging as a threat to the population, and how severe can that threat be? So it's the threat today and then the threat tomorrow in terms of pandemic risk. So again, if you have a virus that changes enough, it can go from an animal to a human, can get really much better at human-to-human transmission. And if it's new and your immune system hasn't dealt with it or things like it, that means that you could have a more severe infection. So I'm going to put us into the COVID space for 1 second. So COVID still causes a lot of people to get very ill. But in general, COVID has become a milder infection for most people because our immune systems have experienced it or the vaccines that we use to protect people from it. Flu is the same. So if there's a new flu that our immune system isn't really taught about, we could have a more severe outcome. So then I'm going to move from that description into public health response and to talk a little bit about how we detect, respond, and prevent so far in the H5N1 space. And so just like the immune system, CDC has used a couple of different strategies to detect what's happening with bird flu. So for those of you who are immune system nerds, there are a couple parts of the immune system. There's the innate immune system, which isn't super specific. And then there's the adaptive immune system, which is the part of the immune system that learns, that's more specific to the pathogen. And so we have a couple pieces of our immune response that really are focused, or detection, that focus on the kind of immunity. So our innate immunity is our syndromic surveillance. So let me unpack that for you. So CDC works with states, and we monitor what happens in over 90% of the emergency departments in the country in real time. So if we start to see strange patterns of respiratory disease, more flu during the time of year we don't expect it, that tends to be an early, but maybe not very specific, like innate immunity signal that there's something going on. We then also use more adaptive parts of our immune system that are flu specific. And so in this circumstance, what I mean by that is if we find a herd in a state that has H5N1, the public health department in that area gets activated, and they work with the farm to monitor people who may have been exposed to cows or poultry or other animals infected with H5N1. And so to date, CDC has monitored 18,600 people with exposures to those animals and has identified 64 cases by that flu-specific monitoring. Now, that isn't the end. We also have our national influenza surveillance system that is industrial strength. And what that is across the country, every state's public health laboratory works with medical providers in its jurisdiction to characterize the flu viruses that are circulating at the time. And so what that means is I go to the emergency room and I get tested for flu. It's flu A positive, just good old-fashioned flu. That swab then gets sent to the public health laboratories where they do an additional characterization of that virus to see if it's anything different or special. So is it the stuff that we expect to circulate or something different? That data is used to formulate your flu vaccine every year. That data is also used to find a needle in a haystack. So since the beginning of this outbreak, local health departments associated with CDC have tested over 200,000 people for bird flu. And they found 2 cases actually, that were people that had no exposures to bird. So that system is a really important piece, adaptive immune piece, that's flu specific, that protects us actually every year, but is really important when there's something new circulating. And then the other piece, a new part of what we're doing, is wastewater. Are you all aware that that folks are testing wastewater for all sorts of pathogens around the country? Well, so we did something based on lessons from the pandemic, from COVID, that we launched the wastewater program in the US, working with our local health departments, industry, and scientists before we really knew everything about how to use it. And so, spoiler alert, we detected H5 in wastewater. The next spoiler is it had nothing to do with human infections, it had to do with animal infections. So we were able to say there's migratory birds in this area, and that's why we're detecting this. This is in the same place where the dairy dumps their milk into the sewage. And so it's a really interesting system. And let's say that there is human transmission or increased human transmission, that's going to be a really important overlapping system that increases our ability to detect. So now the next piece of that immune response to H5 is coordination. So remember I said CDC is kind of like the T helper cell, sending messages and instructions to the effectors, which are the local health departments, medical providers, and people for how they can be responsive to a pathogen like flu. So we do that by coordinating across the US government, as well, and also coordinating with local government. So we coordinate with USDA, with FDA, with NIH, and ASPR, all together through this unified coordination group so that we have a coordinated effort and we shine in the areas that we do the best. So we are about human health at CDC, and we work with USDA closely in that One Health paradigm so we can make sure that we understand what's going on in animal health. So how does that manifest itself? So we fund local public health departments to do work. We send them guidance and the information that they need to create a coordinated response based on data and one that looks similar across the jurisdictions rather than being a little snowflake in each jurisdiction. So for the bird flu as an example, along with our baseline funding, about $200 million additional dollars went out to local jurisdictions to be able to support the response. But also at CDC, we work to characterize the viruses. So every time there's a new bird flu case in a human, we actually get the virus. We sequence it, and then we do other tests so we can learn, is it changing? Is it going to be responsive to the antivirals that we have? Is it going to be responsive to the vaccines that we have developed in the event that we need them? And are there any changes happening in the bird flu that may indicate that it's better at binding those human receptors or causing more severe human disease? And so we also create that groundwork for a vaccine campaign. And so those candidate vaccine viruses that we produce, we just keep banking them. And we have an immune memory. So if we have another thing, let's say another flu virus, like a swine flu that emerges that we're worried about, we probably have something in the bank that can be a good match so that we can move it quickly in the event that that happens. And then the other part of the immune response is really focusing on people and engagement. So another important piece of what we do is make sure that we're talking to the right people, providing guidance to the populations who are at the highest risk, making sure that we're getting info to farm workers, to dairy workers, to poultry workers. And we do that by engaging with their trusted messengers. So not surprisingly, the government is not always the trusted messenger for people who are working on a farm. There's a lot of reasons for that. And so we partnered with national organizations as well as other parts of government that work deeper in the farm worker health arena, including HRSA with their community health centers, OSHA, occupational health, as well as USDA, and this amazing organization called the National Center for Farm Worker Health, which really helped us get the word out. So all of those things are the sort of general things that we do for response, but then there's also very specific things. So we provide guidance on how to use antivirals, which we did for H5N1, how to use them for treatment, how to use them for prevention. We also prep the system for a vaccine campaign. I'll remind you, there's no H5 vaccine campaign. It's not indicated for anybody in the US or in the world at this point. There is one country, Finland, that is actually doing an H5 vaccine, and it's apparently not going super well in terms of uptake because of the fact that people don't see a high risk or a need to get that vaccine. So why is there not a human vaccination campaign for H5 in the US right now? This is my favorite mantra, no human-to-human transmission. We're not seeing durable changes in the virus that make us worry that it's going to be better at infecting people, and there's no trend toward increasing severity. So you can imagine it's probably not very appealing to launch a multi-billion-dollar vaccine campaign to try to make someone's eyes less red, if that's their only symptom. So it's not one thing, it's all three of those things that come together to help make the decision, do we launch a vaccine campaign? And again, I already talked about this a bit, but part of this is also generating new candidate vaccine viruses. So we have things in the bank. So if we have a virus that comes up, we're able to actually generate that immune response for the US. And that sounds like, well, that's kind of nice. You generate these vaccines and these viruses and you keep them in the bank, but what does that mean for me? And for us, for health, it means that shaves up to 2 months off the launch of a vaccine campaign. So we don't have to grow the the virus in eggs and do all the things that we need to do to get it ready. We have it ready, so we skip ahead about 2 months, so we have the ability to produce vaccine quickly and get it into people in the event that we need to do that. And then finally, there's the labs. And I won't go too deeply into this, but we support public health laboratories. We support commercial labs. So we actually have commercial laboratories in the US that weren't able to test for H5 before. And now doctors through Quest and LabCorp and a bunch of other places are able to order an H5 test if they think that someone is at risk and has symptoms. So that's an exciting thing. But also the CDC labs are really important because we keep looking at that virus to see if there's anything changing about it that would potentially push us into a different phase of our response. And so I want to end with, before getting to questions, one of the important roles that we do at CDC is providing a risk assessment. And we do that, again, in two different ways. There's what's the risk today for you and for me, and what's the risk in the future. And so for immediate risk, we ask a series of questions every time we have a case of H5N1 to see if we need to shift. To remind you, we think that the risk for the general population is low, but that there is higher risk for people at occupational or recreational exposures to animals or animal products. So what are the questions that we ask? Not surprisingly, is there human-to-human transmission? Is there a trend toward more severe illness? Are there persistent changes in the virus that could potentially make it better at infecting humans or potentially make it a more severe infection? So the answer to all of those questions so far have been no. So the risk to the general population is low. Now, why is the mortality rate 50% in the rest of the world and only 1 out of 70 has had a bad outcome, meaning death in the US? So the hard answer is we don't really know. But we have a lot of hypotheses and a lot more data that may support the answer. So there could be baseline differences in the health of people in the US versus other places where bird flu has been identified. There could be a difference in the magnitude of the exposure. So it may be different in a farm in Cambodia versus a farm in the US in terms of how much exposure folks have to birds or cows. Interestingly, and this is where the science is getting really exciting, there may also be some protection from prior infection with other seasonal strains of flu. And here's a really interesting story. At CDC, the best model for influenza are ferrets. And so we actually had ferrets who had been previously infected with a seasonal flu, an H1 influenza. They survived that infection, and then they were infected with H5. They survived. That's different than what we saw in naive ferrets who'd never been infected. So there was something about that prior infection that protected ferrets. Then we looked at the population using our systems that look at immunity in general for flu and help decide what your flu vaccine is going to be. And what we saw is there is some immune experience in the US that may protect against H5. And that is likely also because of prior influenza infections as well as prior influenza vaccinations. And we saw that in one of the dairy workers that we did a very thorough investigation of their immune system, that they generate antibodies that are actually neutralizing and protective. So there is something about what we've already seen as a population that may explain why bird flu is not as severe here. And then the last question that's part of our assessment is why aren't we seeing as many cases now as we were last year when we had a good clip of them? And I think these again are hypotheses, but really it's all about the animals. We're not seeing as many detections in cattle right now. We're also not seeing as many detections in poultry. So that means there are fewer opportunities for people to be exposed to those animals and those viruses, so there'll be fewer infections. We also know that people are more aware about bird flu on the farms and are actually using their personal protective equipment more. And we're getting that directly from farm worker health organizations, which is exciting. And then lastly, there are other policy things going on, which I don't have to go into great detail about, that actually also make it less likely for farm workers to want to engage with government, whether it's local or federal. And so all of those things may explain why we're detecting less. Now, that's that immediate risk category. What about future pandemic risk? Well, this is where it gets a little nerdy. We do this thing called the influenza risk assessment tool, and we look at all of the data, whether it's virology, epidemiology, immunology, and we create a package for each virus that we assess and send it to experts and ask them, rate these viruses. What is the risk that this is going to emerge as a threat in humans? And what is the risk that it's going to cause public health chaos? We ask them those two questions, and they grade the viruses. We've done this 3 times with these circulating bird flu viruses. And what they found is, in that assessment, the risk for this becoming a pandemic threat is moderate, exactly where the other bird flus that have been circulating in the globe have been. What does that mean? Having our vaccines ready, having 10 million doses ready to go in case we need it, making sure that we have our public health infrastructure moving and that we have our antivirals ready, we're in the right place and probably ahead of other bird flus in terms of preparedness. So that immediate risk is low, but that vigilance remains, and that preparedness stance is important because its risk for emergence and causing public health chaos continues to be moderate. So I'm going to move to questions in a second, but I want to make one point, which I think is really important. The systems that we use in the everyday public health that we do are the systems that protect not only from seasonal flu, but also from these threats. A healthy immune system is a robust immune system. So if you take my analogy, we really need to focus on the health of public health and the public health infrastructure and the public health experts that are doing the work every day, so that I can sit up here and tell you all about bird flu in great detail. So hug your local public health worker, and in your space, remind all of the folks that are making policy decisions that public health is in fact national security. And with that, I will take questions. Okay, I see, I'm gonna go all the way in the back. There's a question in the back. Gentleman with, I think it looks like either a black or navy shirt. I can't see that far. Something like that.
Thank you for the riveting discussion. My question is about the practice of culling entire flocks and why we don't preserve some of that resilient genetics for resilience in the future against the strain.
Yeah, so I think it's an interesting question, and a lot of debate going on in the USDA and in the sort of animal health sector of the world. One of my understanding from my veterinary colleagues is one of the reasons that it's called highly pathogenic is because it tends to be a pretty devastating infection for flocks. And so it seems to burn through them, and there don't seem to be a lot of birds that tend to do very well because of how pathogenic it is. Now, with that said, there's a lot of discussion about what is the right way to do this. How can we try to minimize impact on flocks? And again, I think some folks have talked about, will there be some birds that are able to survive, and are we able to use those birds to sort of propagate? So I think that is an area of a lot of investigation. And I know my friends over at USDA are having a lot of discussion exactly on that. Right now, the strategy continues to be that if there is a bird flu outbreak in commercial poultry flocks, that they do cull the flocks, but it's a space to watch. Thanks for your question. Let's see. I will go on that side.
Hi, thank you for great discussion.
Thank you.
Okay, 2 questions, very different. Has it been detected at all in house cats?
Oh, yeah.
Okay.
Great question.
And is that a bigger fear for like we have a cat who likes to
Yeah, it's a great question. So it has been detected in house cats. And interestingly, a lot of the detections in house cats aren't because of wild birds, but because of raw food and raw milk. So apparently, and again, I am not a veterinarian, but these infections tend to be really severe in cats. So they, in fact, generally present with respiratory symptoms, and then quickly it gets into neurological symptoms. And so very often, cats get taken to the veterinarian, and people are worried that they have rabies because they're acting strange from the neurological perspective. And so, the real risk to cats is relatively low, but the advice that's all over the FDA's website, USDA's and ours, is to avoid feeding them raw diets because that could increase their risk. And there have been contaminated lots of raw food. I think there was one lot that was turkey that resulted in a bunch of cats getting infected. Yeah.
Second question is, with the current administration and all the cutbacks that we're hearing about in public health, CDC, you've lost 25%, I think. What are your expectations and fears for being prepared for whether it's a bird flu pandemic or whatever is coming next?
Great question. I'll start by saying that my center, the National Center for Immunization and Respiratory Diseases, is actually one of the lucky ones. So we have not had a lot of impact. And if you sort of look at where the impact has happened, it's not really touching the infectious disease space as much as some of the other spaces. And I think that the sort of plan for what the redesign is for HHS and CDC is not yet clear, but it seems as if there may be a plan there in terms of what that can look like. So I think that my main concern is that no program is an island. We're interconnected with chronic disease as well as infectious disease. So my concern is that as this sort of redesign happens, that it's important to remember the sort of nature of response, which is it's not just the bird flu people, it's the bird flu people who talk to the people who work with farm workers who take care of their hypertension. So I think that that's the thing that I'm the most concerned about with the losses in staff, which is the sort of maintenance of the robustness and well-roundedness of the responses. Thanks for that question. Okay, let's go back to this side. There is a person in a blue and white. Yes, that's you.
Great. Well, first of all, thank you so very much for all of your contributions to our health.
Thank you.
Can you talk a little bit about how AI is impacting the work at the CDC?
Yeah, great question. I feel like we're really early in the AI story at CDC in general, but I think that there's a lot of interest in how AI could potentially be used to synthesize large amounts of data. I think sort of looking at the president's budget, one of the things that's being discussed is this biothreat radar. I'm not sure if you caught that one in the president's budget, but it includes an idea of how AI can be used to really synthesize data that is across all those systems. So, imagine all of the sort of parts of immunity that I talked about. Is there a way that we can harness AI to be able to say, there's a signal here, let's do more work, or there's a signal here, let's shift this entire machine to look there to see what's going on. I think that that's where we're heading with AI, but I think that we're really early in those days. Thanks. All right, I will take a question right there. Yeah. Notice what I'm doing.
Thanks.
Left and right.
I assume that if you drink raw milk versus pasteurized milk, you're at much higher risk for bird flu or the H1N1, right?
So we know that exposure to animal or animal products related to bird flu increases your risk. And in general, the guidance that currently exists in public health is to avoid raw milk because of all the pathogens.
Right. So then, since there are pockets of society that are really into raw milk, have there been any thoughts about putting up some special surveillance for those folks? Because I would guess that they're the ones that we're going to see who are not directly working with animals.
Yeah, no, that's a great question. So I think there are some surveillance systems that look at foodborne pathogens, and that's part of the robustness. So we already interact in the bird flu space with the folks that are doing the foodborne pathogen work so that we can identify anything that happens. With that said, it's a great idea to sort of see if there can be a study. I think it's hard to identify. One of the hard parts in surveillance is that it's industrial strength. So I will turn the question back to you, which is, how do I find a raw milk drinker? I don't know. Right. Great. So there may be there may be ways to do that, and it may be that there's a prospective study where we enroll folks. You don't have to look for. You can even do things like look for serologic evidence of exposure. So I think there are discussions in that space, but we're using the industrial strength surveillance systems to try to find things. But definitely, I think it would be really great to see if we or NIH could recruit some folks who are raw milk drinkers to better understand. All of our data is in animals. So mice don't do really well with H5 with raw milk infection, with raw milk that's infected. But again, we're not really detecting a lot of cases of H5 that we can point at raw milk in a human. So there's no documented case where we can point and say that person drank raw milk and that's why they have bird flu. Thanks. All right, let's go. I'm going to bring it all the way to the front to this gentleman here. And I can actually read his name tag. It says Bob at this distance. The glasses are good today.
First off, I want to really thank you for an excellent presentation.
Thank you.
Thank you very much. And
Thank you.
great presentation. And I also really appreciate your support for public health, and which the CDC stands for, of course. And my question is specifically regarding vaccine hesitancy.
Yes.
This must fall under
It's
your purview.
We're one of the people that work on that.
And they just recently, gutted the vaccine advisory, committee and replaced it with members with some vaccine hesitancy and so forth. So what do you recommend for us, and what are you doing in that space where, what can we do to help support public health specifically on vaccine hesitancy, because there's no research going on there now, et cetera?
Yeah, so I think that the best way to approach vaccine hesitancy is with maximum transparency. And so I think that, as you're seeing, more and more data from us in the worlds that you live, whether they're health or not, really providing like the right information to people so they can make their own informed decisions, which really should point them toward, vaccines are, from the perspective of risk benefit, significantly higher benefit than risk. And so I think it's thinking about meeting people where they are. Let me give you a story. So there's a measles outbreak that's happening in this country. And I had the great opportunity to be deployed to Texas to go meet with the folks who were being affected by this outbreak. And, it really is this. And when I was in New York City, I ran the measles response with another population that was really not very interested in vaccinating. So it ends up that you have to meet people where they are and also have some grace. And so I think that the industrial strength message of getting vaccinated is right for 90% of people. For people who are in close-knit communities, that may not be the right message to lead with. The right message may be like, we want to make sure that your kids are healthy, and here's the entire toolkit that you can use to do so. So when I went to Seminole, what I learned was that if we started the conversation with vaccinate your kids, we lost them. It was done. And so instead, having the conversation of how can we keep your kids healthy? And the answer was, Seminole is far away from Lubbock. And that's an hour-and-a-half drive that I did. And if you had a sick kid, that hour-and-a-half drive could mean a pretty sicker kid. And so encouraging folks that if you have a sick kid, get them to care and get them to care fast, and establishing trust with the sort of healthcare organizations were the way to sort of at least bring people closer to healthcare, and maybe have some discussions for folks who are in that movable middle to consider vaccinating themselves or their family. So I feel like, as folks become more skeptical of vaccine, I think that, vaccines continue to be a miracle of public health, and reminding them that A, they're a choice, people can choose vaccines or not, and B, that they're much better than getting the real infection. And that they don't always prevent the infection, but they can often make the infection go from something terrible to something fairly mild. So I think it's meet them where they are, be as transparent as you can. And on the ACIP meeting, I would watch that, because I think that's going to be really, I don't think we know what that's going to be like. I'm optimistic because I provide, through my center, all of the data and science that should inform discussion. And so I'm hoping that that information will be the kind of thing that will trigger like really good generative discussions. But I do think it's one to watch. Let's see, I will go here. And thanks for that question. I could read your name, Bob. Thanks, Bob.
Hi, thank you so much
Hi.
for your presentation. I'm curious about the last comment that you sort of closed with around public health infrastructure and it really being, akin to national security. The public health infrastructure grant is sunsetting, going away, if not already, significantly. Our immunization registries in states are 20, 30 years old. There's only 3 companies in the whole country that provide them. Can you speak to how state and local governments, as well as the communities, can really step up and, as you just said, meet people where they are and maybe create some more upstream coordination as opposed to just CDC?
Yeah, no, thanks. I have sort of a zoom out answer to that question, which is, in different eras, different parts of public health need to rise up. And I think, that can sometimes be local health departments. It can be industry. It can be industry working with local health departments. It can be community-based organizations. Sometimes it's the federal government, not always. I think that this is a time, like as there is like a refashioning of what public health looks like, to sort of, wax a bit philosophical about this and say that the mission is the same, which is to protect the health of people. And it may be that the folks that need to rise up aren't going to necessarily be the ones in the federal government in the event that we're not able to with the same robustness that we have been in the past because of limits in resources, et cetera. So I think it really is a time to think about how public and private partnerships may be able to work together to achieve that common goal. Because again, I don't have a crystal ball, but I think that post-pandemic, we are experiencing the U-shaped curve of concern, something that we talk about in tuberculosis classically, which when there's a lot of TB, there's a lot of TB resources. When the TB goes away, the resources go away, the infrastructure gets not as good, and then all of a sudden, there's more TB. So I think that this is like one of the sort of routine things that we see in public health. It's not the thing that makes us happy, but I think everyone in public health is used to the waxing and waning of their resources. And I think that public health folks tend to be pretty surly and smart in terms of how to get to the end goal. Yeah, thank you. Let's go here in the middle. That's right. I'm challenging the arm length of the microphone, folks.
So my question is about surveillance data equity.
Yeah.
And you've mentioned that it's, so far the disease is pretty mild in the US among people with a lot of exposure who have very specific demographic characteristics and exposures. Unlike me, who did not grow up on a farm, and I don't drink raw milk, and I live mostly in urban areas. So could severity be different for populations that are not being represented in your surveillance?
Yeah, interesting question. So we don't 100% know why severity isn't as bad as it is in other parts of the world. I actually traveled to Cambodia where I talked to the doctors that were taking care of people who come in with bird flu, and they are thunderbolts and lightning sick, going to the intensive care unit, intubated on, like it's just bad. So it seems as if there's something about our immunity, our baseline health that seems to be protective. With that said, we did have one person who did pass away from H5N1 who did have underlying conditions, but this is like where it's weird, where normal flu, seasonal flu, people with baseline conditions tend to be the ones that have the worst outcomes. In a novel influenza, it doesn't matter because it's about the immune sort of memory that we have. So it seems as if we have more immune memory for H5 than people expected. If there's an H9 that pops out and makes all the right moves and we don't have all that same immunity, we could have folks who are like completely healthy getting very sick. And that's what we saw with other pandemic strains of flu. So the surveillance is sort of agnostic to the WHO. The surveillance that's really focused on exposed people is like, it's very bespoke. So it's like a local health department going to the farm and monitoring those people. That blanket surveillance had found 6 cases without known bird exposure, and actually it was ultimately 3. That's what we use to see sort of if there's any significant signals that are happening that would make us more concerned. In the meantime, stay up to date with all of your seasonal vaccines because that's going to be the way to do it. All right, we'll take that person in the back whose name I can't read. White sunglasses.
Thank you. The vaccine banking that you described is wonderful, and thank you for your great description of the workings of the CDC and all you do for us. I'm very concerned as a physician that RFK has said, well, any new flu vaccine we're going to come out with that's, guided towards the seasonal flu that we expect is going to have to undergo a placebo-controlled trial first. You and I both know that if that happens, that vaccine will come out 6 months too late to help anybody. How concerned are you about that? How are you envisioning managing that? I mean, that could be the case too with age 5.
Yeah, I feel like the frameworks that have been discussed, you have to read all of the fine print. So it seems as if for flu, there's not going to have to be anything like that. I think that probably there's already been studies and more studies happening for H5 vaccine to make sure that we understand it. Those are all randomized and controlled, by the way. For COVID, I think that's where it's going to get a little interesting because of the framework that the FDA is putting out from the regulatory perspective. So the way that their framework is written is if you're over 65, slam dunk, get the COVID vaccine. If you're between, I think it was like, if you're 6 months to 64, you should get the COVID vaccine based on their framework if you have underlying conditions, and their list of underlying conditions is pretty extensive, where about 90% of the American population have them. And so I think where it's getting interesting is the recommendation for me. I'm 51, I'm healthy, I don't have the underlying risk factors, although I guess I sit on my couch and watch TV, so maybe I'm sedentary sometimes, maybe. But that's sort of the space where they're looking to say, does there need to be more randomized control studies to figure out the effectiveness and safety of the vaccine? So from the CDC perspective, the data that we have in the real world, our vaccine effectiveness data, really demonstrates that there is a role for the vaccine regardless of underlying medical condition. And so that's going to be a really interesting conversation at the ACIP, because our vaccine effectiveness data really show that. And there is, I think, some debate as to what they would define as sort of gold standard science in sort of achieving the goal of really understanding the effectiveness of COVID vaccine. It's going to be a really interesting area for a few years, I think. Okay, can I take one more or one more? Okay, y'all have to duke it out. Let's see. So this gentleman here with the white hat has had his hand up for so long. So I'm going to take his question. So sorry if I couldn't take everyone's question, but I'm glad you're interested. Wow.
Great presentation.
Thank you.
Looking at this from another perspective, is there robust veterinary research that's looking at vaccinating the animal, catching this from an upstream perspective?
Yeah, that one is really interesting and no really good answer. So I think they are looking. And so there's been a lot of discussion about animal vaccines. If you actually were to track the USDA sort of strategy, it was a learn more about vaccinating cows and chickens, and then that went away. And so I think that there's some back and forth about like what the role is of vaccine, especially in cattle and chickens. So I think the science is being worked on. The question is going to be like what the research has to be and how it can be implemented. All right. Thanks, everybody. Enjoy your few days here. Thank you so much.